Our next speaker is Anita Silvers. Anita was unable to travel, and so she's not here with us today directly, so she's going to be communicating with us by Zoom. At least that is what I...
Can you hear me? Can you hear me?
Yes, we can hear you.
Shall I start?
Yes, please.
Okay, so I covered this topic from a somewhat different direction than most of the earlier presenters. I'm a post-polio partial quadriplegic. I'm nearly 80 years old, so I've seen a lot of cultural changes. And I'm going to talk from a personal point of view. Facts referencing history and culture have at least as much to contribute to shaping healthcare policy that promotes trust as the statistics that most usually are treated as data. Phenomenological information, that is facts about the texture of the conscious experience of individuals for whom the healthcare system appears obdurate, exclusory, even threatening, are an important touchstone for the general effectiveness of purported protective measures. So I'm really focusing on the protections, and I'm going to argue, picking out one, that it is counterproductive. While there's no time here to go into detail about the history of repression and suffering due to disability of individuals targeted by programs of institutionalization, of eugenics, of euthanasia, all driven by healthcare professionals, the well-known outcomes of societal programs like these recommend vigilance. But not every restriction imposed in the name of increasing safety for those most vulnerable effects that aim. So the policy feature I'm about to highlight is pitched as a protection for the kinds of patients who historically have been targets of maltreatment from procedures enacted by healthcare professions and endorsed by healthcare systems. But that appearance masks potential conflicts of interest about who's good, the good of individual patients or the good of individual healthcare professionals and provider institutions is prioritized. And in the implementation of some of these protections, it looks to me as if protecting particularly healthcare institutions, both politically and culturally, and legally, of course, is a priority. And I think that the last speaker gave a lot of detail showing exactly what I'm worried about. So who is good has priority is an ambiguity we can't afford. The we being individuals like me who are supposed to be hyper vulnerable to harm due to debilitation, depression, or hyperbolic dependence. The current requirement on which I'm focused is, as I'm sure you can guess, that crucial medication be self-administered, by which I take it. If you don't happen to have family members to open up 100-second capsules, you have to have enough control of your body to do so yourself. And when I read about that, I looked at my own hands and wondered if I could get 100 of them open without spilling everything. This requirement functions as an eligibility criterion that is supposed to guarantee voluntariness, despite the fact that control of one's body's movements does not suffice to guarantee that what one's body does is voluntary, nor is such physical control necessary. Decades ago, U.S. courts decided that individuals who lack manual control could utilize adaptive equipment to exercise their right to refuse treatment. These were individuals who, most or not all, were respirator dependent. They resided in nursing homes. The nursing homes did not want to turn off the respirators, and they went to court. And the court said, you can use mechanical devices. And it's pretty easy to make a mechanical device. To do so, I believe that there are also mechanical devices available to administer lethal doses. The self-administration requirement may be less likely to reduce the danger that terminally ill people who have little or no control over bodily movement will suffer will suffer unrequested fatal intervention than to increase their distress over a law that explicitly bans them from relief that would be available but for their disability. And I've even seen a model for California hospital policy requiring explicitly that all patients with disabilities, and now I'm quoting, must undergo a thorough assessment for consenting capacity determination beyond what is required by the California Act. The rationale is to protect disabled people who categorically, apparently, are supposed to be unfit to make autonomous and informed decisions. Now, I hope in that same spirit of protectiveness, the cost to the disabled patient in time and money of this specially added barrier will be waived. Suffering this kind of legally endorsed exclusion, having to bear such socially imposed loss of commonplace options due to disability nearly every day, and that's what my life is like, remains one of the hardships of living with disability. Individuals who, due to disability, find paths to their self-selected good locked by imposition of non-disabled people's fears for them must then press ahead even while fearing that doing so may be rash, just to maintain momentum to evade or overcome the barriers. And this is something I've also done, have to do every day, do things I actually think may endanger me, but I've got to force myself to do it because everybody else is telling me that I cannot do it. Usually I can do it. This effect of cognitive bias is familiar to people with disabilities for whom every day brings challenges that can make getting even the simplest activities of daily living into a strenuous crisis. So the current legalization's approach to self-administration eligibility is counterproductive. It coerces terminally ill individuals with progressive deterioration of bodily control into shortening their own lives prematurely in order to maintain their options. No question, I think, but that the current paradigm for legalized procedure is designed above all to shield the agents of implementation, prescribing physicians, or the institutional infrastructures in which they have to practice from suspicion. This is absolutely no way to maintain trust between patients in the healthcare system. Now, there are comparatively few good studies of the cognitive biases introduced by the social stresses of living with disability, in part because even the boundaries establishing who is disabled are unclear. A 2012 U.S. Census Bureau report derived from the 2010 census points out that, I'm quoting, the agencies and organizations that provide benefits to, advocate for, or study these populations each refer to their targeted group as people with disabilities. But because of the differences in definitions, an individual may be considered to have a disability under one set of criteria, but not by another. And that is probably the last point I want to make about the attempt to protect individuals due to disability. Sometimes people argue that anyone who is terminally ill is disabled. If that's the case, then it does seem that these counterproductive protections should not apply to anybody. That's really all I have to say. Can you still hear me?
Yes, we hear you. Thank you very much, Anita.